Ladies and gentlemen, thank you for joining the Lake Superior Quality Innovation Network Quality Improvement Hospital, OQR, ED, Throughput measures. Your host for today is Dr. Michener. Please begin.
Thank you. Good morning, everybody, and welcome to today's webinar presented by Lake Superior Quality Innovation Network. The Lake Superior QIN is comprised of three organizations: Empro here in Michigan, Metastar in Wisconsin, and Stratus Health in Minnesota. The purpose is to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. Today's webinar slides are available to download on the login page for the event. At this time, I would like to introduce you to today's speaker. Dr. Rahul Mehta is the chairman of the Department of Emergency Medicine and Deputy EMS Medical Director at St. Joseph Mercy Open Hospital in Pontiac, Michigan. He is also an attending staff member of the Emergency Department at St. John Providence Hospital. Dr. Mehta is board certified in emergency medicine and has been practicing clinical emergency medicine for more than 15 years. He earned his medical degree from Wright State University Medical School in Dayton, Ohio, and completed his residency in emergency medicine through Wayne State University in Detroit. At this time, it is my pleasure to turn things over to Dr. Mehta.
Good morning. I hope you can all hear me. I can't believe I'm practicing for 15 years. So let me get down to the basics of this talk. We are, as emergency medicine physicians, one of the new things is, one of the measures that we're judged on quality is how quickly we can move our patients through our department. And we struggle with the traditional approach of we take care of the sick versus we realize that we still take care of the sick, but we also have to take care of the walking wounded and how to get them through our department in an efficient manner while taking care of the acutely ill and the ones that we admit to the units and the ICU. Healthcare, as you know, is changing, and a lot of our measures are based on how quickly we see patients and discharge patients and our throughput measures that we're judged on, as well as the patient experience. So let me start with the first measure. As we know, we have 5 things that we kind of look at: arrival to departure time, median time of arrival, and provider contact, the percentage of left without being seen, because that's real money in there. You read studies out there that every left without being seen patient is lost revenue. Arrival for pain medicines, as well as head CT for stroke patients. So one of the things about head CT and stroke patients is test the efficiency of your department for a high acuity patient. I'm proud to say that our department has achieved the stroke elite status, and a lot of it's done through process improvement and quality measures and systems approach, but we'll get to that at the very end of my talk. So ED throughput, we have benefited from what we call a lean approach that we developed from what we traditionally did in our ER to what we are doing right now. And a lot of it came through coordination through what we call a process excellence team, which is basically people that have been certified in lean strategies through coordination with our nursing staff to develop an approach that has been brought in by the ground up instead of the top down. So one of the big decision things that we changed was we changed our ER from a basically one acute section and one not acute section to a pod section. And then we developed another section within our ER, what we call vertical lean, and then we developed 2 coordinators with our nursing staff. And this is coming from nursing literature. There's papers out there that talk about pivot nurses. And so we didn't use the term pivot nurse, we used it as a front-end flow coordinator, and then we use our traditional term in the ER that we all know about, which is a charge nurse in the back. So a front coordinator as well as a charge nurse in the back to help coordinate and manage flow. The other thing is we pull to full, and we all talk about pulling to full, and that is the biggest cultural change that ED leadership and ED management has to struggle with. There's a traditional way of doing things versus the new culture change. And direct vetting with bedside registration. So one of the things we got out of the lean approach was to kind of keep the staff totally engaged. This wasn't coming down from top that we're going to change this because we decided to change this. This was getting ideas from the bottom up to figure out ways within our layout. Every ER is, as directors, we would like a different ER, a bigger ER, things that need to be changed. Our ERs are normally designed for our volume 4 years ago versus our volume right now. And so we use this visual management thing to constantly keep the staff engaged about seeing what our progress is, coming up with new ideas, fixing things on the fly, and then developing what we call an A3 approach, which is actually from lean technology or lean metrics about keeping employees engaged. And employee engagement was key to this. So one of the keys, and I'm going to talk about two main themes here, and both of them need to work together. One is process change, and one is cultural change. Process change is looking at what you're doing and seeing how we can tweak the process. And culture change is the hardest thing to do, which is how do we change our mindset from a traditional way of how we approached emergency medicine to the new realities and the new way we approach emergency medicine. I trained in a program downtown, an academic center, where it was more of an indigent, lower socioeconomic group, and you took care of the sickest of the sick, meaning when I trained, I spent most of my time in the trauma room or the resuscitation bay, and not so much of my time in the low acuity or fast track area. So, and triage was as a gate measure or like a stopgap that nursing and physicians use to control their flow. So one of the big cultural changes is to realize that triage is allocation of resources, not an intake process. And it's become an intake process or a funnel. We all know as nursing staff and as physicians, we can tell who's sick. And we can tell who's not. A high acuity patient that shows up in the ER gets straight brought back to the resuscitation bay. That's easy to figure out. The one that's coming in for the ankle sprain, we can all easily say that goes to fast track. It's those patients in the middle. And that is where the funnel comes in. You've got the front 1 or 2 or 3 people that funnel those patients in. And if you're in the back of the funnel line, it takes forever to come back. So, and it's evolved into triage to intake. As healthcare has changed, there's more and more forms to fill out from nursing staff. There's the sepsis forms, there's the travel forms, there's all this other stuff, paperwork that we all do, that is all part of, morphed into this, what they call the triage process. A 20-year-old or a 25-year-old abdominal pain is essentially the same patient, and they're in the back of the funnel line because they're not sick enough to go straight back to the resuscitation bay, and they're not low acuity enough where they go straight to the fast track area. So one of the things, and I'm going to go back to this theme of process and cultural change. One of the process changes that we did, and we're limited in our department. We see about 65,000 patients right now. We're designed to see maybe 50,000 patients. Is we allocated an area where we put chairs, which is the concept that I first read about it coming out of Arizona and Texas, where patients don't always need a bed. When you put them in a bed, you increase their length of stay. So we designated an area of 8 or 9 chairs for like people that are coming in for hand laceration, a stubbed toe, ankle sprains, knee strains, wrist sprain. They don't need a bed for this. And they don't get put in the back of the queue. So the front end flow coordinator, which is the concept that we talk about, the process change, will see an ankle sprain when they get registered and quickly move them over to the vertical lean area, because that's what their triage is. They see an ankle sprain and they go, oh, you're here for an ankle sprain. Let's get you over here. They get back to the vertical lean area where their workup is done, whether it be an x-ray, whether it be a splint, whether it be a wound check, right back to that area. So they don't get put in the general milieu of all the other patients with abdominal pain and chest pain and a mixture of abdominal and chest pains in the main ER. So the idea, and if you look at it even from a physician and a nursing perspective, if you've got 5 patients that show up and you've got 2 with chest pain, 2 with abdominal pain, and 1 ankle sprain, your nursing staff and your physician staff is going to say, let me make sure the chest pain is not having a heart attack. Let me make sure the abdominal pain doesn't have a surgical emergency. The ankle sprain gets put on the back burner. When they have to order blood tests or anything else like that, it gets put on the back burner. So it's away from the general area of the ER, kind of like a separate area within the area of the ER. It's kind of like, I look at it from the hotel literature, where now you notice that hotels have a main hotel, and then they have a concierge level within the hotel, and they kind of like allocate resources differently. So it's a separate area within the ER that kind of functions autonomously by itself. So what we found was, when we use lean principles, you say, okay, 75% of my patients are going to be seen and released. So how do we decrease that 75%, the throughput time? So you can look at it as one big chunk, or you can divide it up. And you say, okay, an abdominal pain is going to require a certain amount of workup. A chest pain is going to require a certain amount of workup, just inherently of getting lab work, getting x-rays, getting reevaluation, talking to physicians, et cetera, et cetera. But the low acuity patients, they're just going to require 1 or 2 resources. So how do we decrease the overall length of stay of those 75% of patients that we see and treat? So let's allocate about 30, 35 patients in our department that are low acuity. So what this graph shows is that when we started this process, we have gotten people on those low acuity patients seen and released within 100 minutes. Sometimes we'll get them down to 60 minutes. So if you look at that big number of 75% of your patients, and you say there's like 10,000 hours of them in our ER, if we can eliminate that small chunk and we get them down from, instead of 150 minutes down to under 100 minutes, or down to less than 80 minutes, it'll eventually shrink that door-to-discharge time of all our patients totally. One, our patients have a higher satisfaction rate because they are seen quickly. They're not in the general mix of all the other sick patients. They want to have those. They want to come in, get treated, and get out. So now that we've allocated the concept of a vertical lean area, one of the other process changes that we developed with our cultural change is providing an avenue to reward best work. And when I say best work, or best practice. So when you change your ER from a traditional approach of put them in the first empty bed to having different pods competing against each other, the cream rises to the top. What usually happens, and I see this in different ERs that I've worked at and colleagues of mine in different ERs, is that if a group of nurses is working really efficiently in getting people done, getting them worked up, getting them disposed, getting them admitted, getting them discharged, how do they get rewarded? They will get rewarded because they get more patients. So if you're efficient and you're hardworking and you're getting things done, your benefit or your reward is, well, you've got the extra patient because that other pod has all their rooms full, and you have the first open room, so we have to put the patient in your room. So that creates burnout. I mean, ER physicians, ER nursing staff, have a high rate of burnout. For an ER nurse, it's a few years, and then they either stay or they move on to other fields. They get burned out with constantly being bombarded with patients. So how do you reward efficient work? How do you make everyone to that level? How do you, as a physician, say, oh, I go to this nurse because I know they get this stuff done. I don't go to this nurse because it takes forever. So you use that back-end charge coordinator to help funnel resources to that bottleneck. I mean, naturally there are times when that one simple abdominal pain can turn into a mesenteric ischemia requiring multiple nurses in the room, and they get bottlenecked. But how do you reward efficient work? So if you even the flow with the front-end coordinator, that each pod gets the round robin. So the idea is that everyone gets the same workload. You reward efficient work. So the idea is that if you have done your 10-hour shift in the ER and you're a nurse and you're efficient, then at the end of the day, you're going to have pretty much an empty pod versus your neighboring pod. And then the back-end charge nurse can kind of like use the resources and go to the area that needs the most help. I mean, do they need an extra medic? Is there an issue with this patient? Is that why this nurse or this team is sinking versus another pod? So it's a way of creating even workflow, rewarding efficient work in the beginning, as well as using the charge nurse in the back instead of worrying about what's in the front because someone else is allocating where patients are going, is looking at what's in the back and focusing on the bottlenecks. So this is a sample sheet of how, it's very basic, with the front-end flow coordinator, and we used telephone. So when the radio came in and there was an EMS coming in, they would get allocated based on these different pods where these patients would go. So you won't get one pod getting 3 ambulances in a row. The ambulances would be spread out. And vertical lean, since they were taken out of the mix, and if there was an opportunity for the front-end flow coordinator, they would just quickly shift them to the vertical lean area, and they won't be part of this round-robin approach. So that way, those very, very low acuity patients will get seen in the back with a vertical lean area. The pod system would create efficient work and reward efficient work. The back-end charge nurse would be responsible to kind of like fix the bottlenecks in each system. And then you would have little twerks that we got from our staff, which is skip turns, meaning that if you had a patient that required a lot of resources, they would skip the next round, and everyone would kind of understand that because, my God, they just had a really sick patient that turned into a really sick patient over there. So how does this help? How does this help the overall process? So going back to this thing of process versus cultural change. So the idea of the cultural change was, let's get them to the back where they really came to be treated, right? I mean, using a restaurant analogy, you go to this restaurant, you don't want to be in the lobby, you want to be in the back. You want to be served your food. Just like here, when they come in, they really don't want a lot of information. They want to be back to be seen and to be treated. So it's the idea of, if you get them to the back, then you put on the process change from the physician side, you say, okay, how do we allocate resources so that you can be seen quicker? One of the big things that a lot of directors have when I talk to people across the country is, my docs say if they could come to the back, they could be seen, I can get orders done. And, a lot of our nighttime docs say, my biggest problem is if there's 10 in the waiting room, if I come in at 10 or 11, I know those patients will eventually come back. But by the time they get back, all the other staff in the afternoon are leaving. So I am behind the 8 ball to begin with. But if you get these people back quicker, you get the orders in quicker, you get the evaluations in quicker, you can get the disposition done quicker. So the idea is those 75% of those patients, or even the ones that are admitted, the quicker they're seen by a provider, the quicker the orders are done. Because you've evened out the workflow, one team isn't bogged down with all 5 new patients, and by the time they get to the 5th patient, it's behind the 8 ball. So everything gets done quicker. Then you can stress the other sections of your department that give you issues, meaning radiology and lab. You say, listen, I've got my orders in. Why isn't my x-ray read? But if it takes you 40 minutes to get that x-ray in first fix your part before you can go to other departments or other service lines to help fix their part of the process. So this is a graph that shows median arrival time. So as you can see, when we kind of started this, we had some bumps. I mean, in February and March, I'll be honest with you, our volume was 32% above budget. This is a bad flu year, as we all know. But if you notice that we had a consistent trend of going down to the 140s, the 150s, and we have a light day, which 2-3 years ago would have been a busy day, we are down to 120, 150 minutes of seeing patients, of arrival to discharge of these patients. So it goes back to we all are challenged with patient experience. I don't think anybody's got the complete answer for patient experience, and it's nebulous and it's got multiple different things. But one of the things that they've talked about is that people want to be seen, treated, and have a disposition in mind. And the quicker we get things with this process, we hope to improve our customer service scores. And as you can tell, we were reasonably pretty good to begin with, but as we've improved and as the pods have become more and more efficient, our customer service scores have also increased. So the other cultural change, and this is process versus culture, the two big themes that I'm going to be talking about, is the cultural change. We've talked a lot about the cultural change on the nursing staff and the hospital side, but there's also a cultural change on the physician side, meaning that normally it was like when you came in, you would see all the patients, and then you would concentrate on seeing the new patient if there was someone to be seen. But the cultural change is dispositioning your patients first. The idea of queue theory, if you can dispose your patient first before you see the next patient, it actually decreases the workload on you. Because, you know, the most inefficient physician is the one that has a list of 10, 12 patients, and then everyone's waiting for stuff to come. Everything's fast, but he's not making the dispositions because he's seeing another patient. The most efficient patient is serially disposing of his patients, meaning admitting them, discharging them before he sees a new patient. So it actually increases efficiency, opens up that bed for the next patient to come in. And the other cultural change that I didn't really emphasize on this, but is what we've kind of done with our staffing model, is that we staggered physicians in. We brought people in every couple of hours, so there's always someone fresh on the horizon. And we brought people in before the actual peaks hit, an hour or two before the actual peaks. The other cultural change is we decreased what we call the funnel of triage. It was a big cultural change to realize that triage is not a gatekeeper. You know, when an EMS comes in here, and this is the cultural change that we achieved, they go straight to a room, right? And so I remember when we first started changing this culture, it was like, oh, well, some people come in for EMS, they don't need to be here. Well, let's just put them out in triage. And I said, well, if you put them out in triage, what are you accomplishing? He goes, well, it'll teach them not to call the ambulance, then they have to wait. And I go, isn't that the thing that we want to eliminate, that they have to wait? So even subconsciously, people realize that if you put them in triage, they'll have to wait. So why don't we say, if you come into the front door, which we want people to do, let's have them as a walking EMS. If they come into the front door, you bring them back to a room. Just like EMS, they go straight to a room, and everything gets done in a room. No one has a problem with that with EMS. So let's use that cultural change, but let's fill these rooms up, have them as quote-unquote walking EMS. They're coming in to be treated. Let's get them back and prevent them from being in that funnel of triage. So filter full before triage. And this is really one of the big fundamental changes that you have to achieve in your ER, is to eliminate that culture of intake and triage and have triage as your last resort and to bring them back to your full. So through this, everything else kind of decreases. You know, the arrivals provider goes down. So you reflect your staffing changes based on pre-arrival. So one of the things that a lot of times when we traditionally staff, we look at how many people arrive in the ER based on the hour, and we staff to make sure that there's X amount of providers based on the number of people that arrive. But what we need to really change is people don't see patients in their last hour of their shift. If you look at how doctors and NPs and PAs see patients, they always front load. And usually in the last hour or so, you're just disbarring. So you're not really a helpful person unless someone's really, really sick. Are you picking up patients in your last hour of your shift? So why don't we staff based on that premise? Meaning that if you're not going to see someone in the last hour of your shift, let's staff based on what's coming in an hour before. And so then you staff according to that concept of people that are fresh and seeing patients. So you stagger people coming in, you stagger your providers an hour before the actual arrival of the patient, because that way you know they're going to see those patients. The last guy finishing in the last hour isn't going to see those patients. So if you look at when we changed our culture of triage, our door-to-provider time has consistently gone down. Now, there have been times when it's been up during our flu season, but we have really strived to decrease the door-to-provider time. So this is also a reflection of left without being seen. So the concept is if you get them to the back, they're more likely to stay and even if it's crazy in the back, the idea is that people are understanding. There's goodness in people's hearts. If they know that you're in a room resuscitating a patient, they're not apt to say, oh, I understand, I'll wait my turn, versus if you're in the waiting room and you don't understand what's going on in the back. So, it's kind of like on stage, off stage. If they're in the back, they can kind of see what's going on. They understand where they are in the line. They're more likely to be seen by a provider instead of in triage. They go, well, listen, they can't get me back, I'm going to the next ER. The low acuity patients don't get funneled to the back of the line in triage. They get sent to vertical lean. So it decreases the time in the waiting room. The ideal is to have your waiting room just full of visitors, not to have anybody in your waiting room, to have everyone in the back. So if you notice our left without being seen, there's a line that shows that we've dramatically decreased. I mean, I don't have the graph for these last days in July, but I can tell you we've had 10 days of zero left without being seen. And we reached a stage where we had 225 patients, which is huge for us. We average 175, and we had one patient left without being seen, which I think is a success. And these successes are celebrated through our huddles and through our department all the time. So how does this help the other measure that we talked about? In the beginning slide, there was 4 or 5 key points, and it goes back to process and cultural change, right? So this is the median time to receive pain meds. So, one of the issues is, the little old lady that, fell and broke her hip, and they come in by EMS, they get their pain meds pretty regularly. The ones that we fail on is the young child with the broken wrist that's waiting in triage, and by the time they get back, they don't get their pain meds because it takes longer. They don't recognize it. It's the last on their list. So the idea is if you get people back, the 10-year-old child with a broken wrist can be sent to what we call a vertical lean area, and they can be seen quicker. The other thing is we did was, and this came from the staff from below, is they said, well, we're giving Tylenol and Motrin to these patients. Instead of us running back to the main ER for the Pyxis machine, why don't we have a Pyxis machine in our vertical lean area? So we did that, and we found that it was an easier way for the triage nurses as well as the vertical lean nurses, because we kept our vertical lean right near the front of our ER to quickly give meds, Tylenol, Motrin, and also we emphasize with our physician staff and our nursing staff to document, did they receive meds at home? Did they refuse meds at home? That way, if those measures can be taken off, it's got good documentation. 2, the process change of getting these patients at a Pyxis machine right where the patients are, and 3, the cultural change of these low acuity patients can't be in the back of the line, they need to be sent to an area where they can be seen quickly. So this goes back to my last measure that we talked about, and I think that this is what we worked on with our Department of Neurology, our stroke neurologists, as well as the hospital, as well as the ER physicians, is a process to increase the speed of getting CTs and getting TPA on patients. 50% of our patients that are TPA eligible get TPA within 45 minutes. We are the highest designation for stroke, and one of the process changes that we instituted one was when EMS arrived, and I sit on EMS committees, is we've instructed, through education, of EMS recognizing strokes and stroke symptoms and calling that in as a priority one. So it mobilizes our resources. We've coordinated with radiology that as soon as they arrive, we don't even get them off the gurney onto a bed unless they're on, Coumadin, where we have to get blood first. Otherwise, we do a quick exam right at the front desk when EMS arrives, and we send them straight to CAT scan, clear a table, get the CAT scan going. So once the CAT scan's going, then radiology knows that this is a priority one read. So they stop whatever else they're reading, and they read this study, whether it be in the CT scan room or whether it be in their reading room, which is right next door. So that has sped up our process, because one of the holdups is you need to have a CT scan that shows there's no bleed. So we eliminate those minutes right off the bat. The other thing is that we mobilize our pharmacy, meaning that we call down a pharmacy and we give them a heads up, hey, this candidate may be a candidate for TPA. So the pharmacist knows that as soon as they have to stop what they're doing, and we'll call them back and say, yes, I need you to get TPA for us or don't get TPA for us. So that process, with the CT scan process, has helped decrease our door to TPA time, as well as a variety of other measures. So the straight to CT scan has really improved the process. The pharmacy early recognition of telling them ahead of time that we need TPA, in the sense of once we mobilize them, they will walk up the TPA for us. In the daytime, we have a pharmacist here that has actually sped up our process more than anything else for door to TPA time. But in the off hours, at least pharmacy will walk it up. We're not waiting for it to be tubed up. We're not waiting for a pharmacy tech to bring it up. The pharmacist will bring it up if they're not busy. And the radiology process of getting a quick read. So this is our stroke elite status that we just got awarded for this process. So in summary, process and cultural change need to go hand in hand. I think the lean process that we have with the hospital to tweak different things, but the cultural change, the culture of triage, from the nursing perspective, the culture of disposition first, not have a big list. The idea of rewarding efficient work, meaning don't punish your nurses that are efficient, that are discharging their patients, working up their patients quickly. The idea of getting those low acuity patients out of the general mix of triage into an area where they can be seen and treated. The idea of employee and staff engagement through constantly pointing out things that we're improving on, successes, developing different process improvement things that's coming from the ground up to see how we can tweak the process. So the other thing is, from a physician perspective, is how we staff, meaning staggering staffing, bringing staff in an hour or two before the bolus hits, to constantly have a new provider on the floor, to work on the lean process of going straight to CT, working with EMS to educate them about the symptoms of stroke, changing locations of our supplies, meaning we change the Pyxis where it is. We changed some of our staffing supplies. Splint material was put in a vertical lean area because instead of them going to the central supply area, it was wasted steps. We put it where the patients were. So the idea is, don't use your ER as, oh, we can't do this because we have limitations. work with what you have and develop the concept that it's all about the patient. How do we get the patient seen quicker? The patient will have a better experience if they're seen quicker. And one of the cultural changes I did institute was, we all know that as staff members, if a loved one comes in, or a physician's relative or a nursing staff's relative, they don't wait in triage. They get brought straight back. So there's somebody's aunt, somebody's uncle, somebody's son or daughter. So the idea is we would do it for our staff. Why don't we do it for everyone else? And that's it. Is there any questions? Hopefully there are.
Does anybody else have any questions? Does anybody else have any questions on the line? If not, I have a few.
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. Our first question is going to come from Barbara Codron. Please go ahead.
Hello. Thank you for this presentation. It's very good. I'm wondering what kind of staffing do you have on your lean beds?
Okay, is this nursing staffing or is this physician staffing?
Nurse and physician staffing.
Okay, so what we do is we have one nurse and one NP or PA, and then we used, so what the lean staff we've allocated from about 10 to 10, and then we can, if the volume is there, we'll staff it up to 3 a.m. in the morning. And so the charge nurse in the back, let's say the lean nurse is being overwhelmed with a bolus of patients. Sure, he or she will send a medic or another nurse to help, meaning that to help with the bolus. For our physician staffing, we have an MP or PA because most of these are ESI like 4s and 5s, and then we have a scribe with the MP and PA, so they don't spend time documenting as much as well as seeing patients. So the scribe can do the documentation, so they're not at the end of the shift spending an hour and a half documenting and not seeing new people. They can constantly see new people and document, and then we use our MPs and PAs to stagger. I mean, the last hour of the shift, we have another PA coming in to get the backlog and to constantly keep it moving. And then they sign out to that PA, so it's a constant flow, not like, well, I'm busy in my last hour, I can't really see anybody.
And do each of your physicians have a scribe assigned to them?
They do. We have found it. We've developed our own scribe company, and actually, from physician wellness, it's been a huge benefit. It's made us more efficient. I think it's given us more time with patients. So one of the things that we're initiating right now is that we have our scribes, as we are talking to the patients, they'll go to the whiteboard and write down my name and write down, and as I'm telling the patient what the plan is, they'll write down lab work, x-ray, CT scan, and so the family has a visual cue of what we're doing. I can spend time talking and informing the family of the initial plan, and then I'll be honest with you, their handwriting's a lot better than mine. And so then when I go in and check on them, I can check off these different boxes.
Good. My last question is about, have you done anything on the admission process to get your patient throughput decreased for door to the floor?
Okay, so we're working on 2 or 3 new projects, right? So one is what we call a ready to move icon, meaning that the floor nurse or the ER nurse has about 15 minutes to calls up there, and then the floor nurse has about 15 minutes to either call down or they get sent up. So within that 30-minute frame, they can call down for questions, or their ER staff will take the patient up. It's not ideal all the time. We've been pretty good with our compliance. There have always been issues with, is this patient stable enough for the floor, et cetera, et cetera. But we've allocated that vitals will be done an hour before they get sent up. We're still working on that process. The other things that we're thinking of is developing like an iPad or a face-to-face, meaning one of the things that when you read some of these HCAP scores is that they felt the care was episodic, meaning they're in ER, they have a care, then they have to repeat themselves when they get to the floor. No one's talking to anybody else, quote unquote. Even though we are, So the idea is using iPads and maybe doing face-to-face communication. So you have the iPad and the inpatient nurse and the ER nurse can look at the patient and they can ask questions, say, this is Mrs. Jones. She's going to be admitted for a hip fracture. This is your nurse, Mrs. Smith, on the floor. She'll be taking care of you when you go upstairs. So they feel that the care is being transitioned. That's one thing that we're thinking of doing.
Thank you very much.
Before we take the next question, Jennifer, could we pull up the evaluation questions? Please take a moment to let us know how we did by filling these out. Katina, are there any more questions?
Again, ladies and gentlemen, if you have any questions, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. Jennifer, there are no callers in queue at this present time.
Dr. Mehta?
I do apologize. We do have one from Deborah Sanowski. Please go ahead. Ms. Deborah, your line is open.
Hello.
Hello, how are you?
Great. Listen, I had a question. Do you use any nurse German protocols to expedite?
We do. So one of the things I didn't go into the minutia was, in triage, one of the things we did find is that if we brought people straight to the back without an EKG, the time for getting an EKG within those 10 minutes was longer. So there was an article published a few years ago that looked at about 3.5 million patients that presented to the ER with chest pain or chest pain equivalent. And, so you're kind of handicapped. There's some places that EKG everyone, which is that you just bog down your front end. And so we used this AHA article that looked at 3.5 million patients, and we developed an algorithm based on if you're 30 and over, you have chest pain. If you're 50 and over, you have syncope. I don't recall it all offhand. It's all posted in the triage area. So one of the two caveats that we did compromise with the nursing staff or work together, I don't say compromise, but work together is if they had any of those criteria, they got an EKG up front because we found it was more efficient within that 10-minute window. Two, if the rooms in the back were full, we did vitals. Otherwise, when filled to full, we didn't do vitals. If you're like an ankle sprain, we didn't waste time doing vitals in the front. We moved them to vertical lean and did vitals over there. If there were empty rooms in the back, we brought them straight back. Just like in EMS, they come straight back and they get vitals in the room. They get vitals in the room. So the idea was to minimize a lot of front-end nursing triage protocols until we're really backed up, and then we use the standard, chest pain, abdominal pain ones where they draw blood work and an IV. And then the back-end nurse or back-end charge nurse will send a medic out with an MP or a physician to order blood tests to get things going. Did that answer your question?
Yes, thank you.
Again, ladies and gentlemen, if you have any questions, please press the number 1 key. Again, if you have any questions, please press the number 1 key. Jessica, there are no questions in queue at this time.
Dr. Mehta, this is Dr. Bichner, can you hear me?
Yes, I can.
So a quick question. It seems to me the way to decrease throughput time in the ED is to get the patient as close to the decision maker as quickly as possible after arrival. So have you explored the possibility of putting a doc or a mid-level out at triage? Because it seems to me that would decrease throughput, it would increase patient satisfaction, it would take the pressure off the triage nurse, and it would virtually eliminate your left without being seen rate.
We've talked about that concept, but the cultural change I wanted to change was let's eliminate the front and get them to the back. So triage is only when everything else is full to the brim do we send someone out. Because the idea is that why put more resources out front? Why not put resources in the back and eliminate that whole front end process? Now, as a staff, we said, okay, instead of putting someone out, let's say an ankle sprain, here's a great example, an ankle sprain, instead of them putting them out in those 2 triage bays, we only have 2, why not get them to the vertical linear, which is right adjacent to our triage area so they can just be quickly funneled over there, and that triage room is constantly open. So the idea is that you don't have anybody in the front, you have them all in the back. But we have explored that when it's really tied up and everything is full.
So, of course, the idea of getting them to the back only works as long as you have people that are being moved out of the back upstairs.
That's right.
So what I'm thinking of is the ES3s. If the ESI 1s and 2s come in, they go directly back. 3s and 4s go to your vertical lean. But for the 40% or so who have ESI 3, you need some decision making. And so, for example, if somebody comes in with right lower quadrant pain, you can just shut them right over to the CT scan. If they have worst headache of their life, you can send them over. If they have a stroke, like you mentioned, stroke symptoms, like you mentioned. These are the kind of people where, triage nurses may not be as facile as the docs or mid-levels in terms of making the immediate decisions. So I'm not talking about the ESI 1s and 2s and 4s and 5s. It's just that gigantic middle group there.
Yeah, it's that middle group that, as most ERs, we struggle with, right? Because those are the ones that get put on the back burner, right? I mean, the priority 1 stroke gets whatever he or she needs. The 4s and 5s, you develop a culture where they get prioritized to get their stuff. It's the 3s that get delayed. So one of the things on the process in the back, when you look at those swim lanes, we look at what are the big holdups in the process in the back on those things. So we looked at lab and radiology, which are 2 service lines, and how do we tweak those processes to make those, like a right lower quadrant abdominal pain, how quickly can we get blood working, get a CT scan or ultrasound preferably to evaluate them. So we have looked at that physician triage or MP in triage. I think the places that I've looked at it that do it on a regular basis usually use a physician. One, because sometimes MPs order too little or too much. And a seasoned physician, one that's, not a new physician. You want someone that's been around for 10, 15 years that knows some of the nuances with that, institutional memory or cognitive memory can recognize those sicknesses in order to have. That's one concept we have thought about when we are really backed up. And then the other end is working on the back end. We were struggling with border hours. I'll be honest with you, the hospital has become, and the cultural change in the hospital is they realize that ER holding issue, it's not perfect yet, it's still a work in progress. ER holding is hospital holding. If the ER is backed up, the hospital is backed up. So the idea is that the logistics people in the back are working to try and get beds to empty out the ER. That first priority is to empty out the ER because those are customers coming in.
Yeah, I like the idea that they have 15 or 20 minutes or so upstairs to take the patient. Otherwise, they move up because their halls are wider up on the floor than they are in the ED.
Yeah, I know that Peter Vicelli's argument of moving in the hallways. I'll be honest with you, I broached that once and that was shot down pretty dramatically. That's a cultural change. That's a big mega cultural change that we haven't achieved yet.
Yeah, and they use all kinds of excuses like the fire code and all that kind of stuff. As if we don't have that problem down in ED. Next question: do you use ATPs, advanced treatment protocols, for the nurses?
We don't use a lot of those. I'll be honest with you, I've been really working on the idea of limiting resources up front and getting people in the back, because that was our biggest holdup. And I talked about the night docs, because I've always been, as a director, you always want to protect those, in the nighttime, because they've got no one else new coming in to see patients. They keep on coming in. The worst thing for a night doc is to have a waiting room full of patients, and they're coming in knowing that no one can come to the back. So the idea is if you can see these people quicker and disbone quicker, so if they come in and all they're responsible for is the ones that come in after their shift starts, it creates a better wellness thing for those night docs. And we have fortunate that we have a dedicated crew of night docs. And so the cultural change is to decrease resources up front and pull things in the back. What I'm always afraid of is the more things I put out front, the more excuses that, we're just going to do this ATP up front, we'll see the next patient. The less reasoning is to get them to the back.
Okay, thank you.
Katina, are there any more questions?
No, there are no more questions. Thank you.
Hey, thank you for joining us today for the Quality Improvement Hospital OQR ED Throughput Measures. Today's webinar slides are available to download on the login page for the event. A recording of the webinar will be available within the next week on the Lake Superior QIM YouTube page. This concludes today's webinar. Thank you.
I would also like to say thank you, ladies and gentlemen, for joining. This completes your conference call. You may disconnect and have a great day.